active is related with lower perception of pain. If we can move the neural gate in our brain might decrease the perception of pain. Mobility has been shown to be, physical activity has been shown to be related to lower risk of depression. Also, when we are mobile, it's less easy to gain weight than if we cannot move. It lowers risk for cardiovascular and respiratory disease. And it's related with better overall health. So mobility is very, very important. And therefore it should be prevented to become immobile. So the doctors should focus on those ways of helping women so that they will not become immobile. And when I talk about mobility, even small physical activity matters. I will focus again on psychological perspective here. Okay. So sometimes we can move, but we don't move because of the shame. For example, I will not go to the swimming pool because I look so bad and people will comment upon me. And actually people will comment, that's the difficulty here. I mean, people can comment. So it takes a lot of courage and it takes a lot of strength, inner strength, to actually be mobile. So if you're working with patients, you might ask them discuss with them what are the barriers to be more mobile. And by more mobile, I not necessarily mean running or active exercise. It's just like strengthening your muscles or stretching or Pilates or whatever you can do. Even small activities. There are research showing that even very small 5-minute activities are helpful. Okay, so now I move on to appearance-related distress. We found that this is very important predictor of quality of life. And appearance-related distress was measured with the Riford Appearance Scale, and it is defined as both negative emotions related to appearance and also behavioral avoidance, so avoiding of certain activities because of the difference in the appearance. So as I said before, I will not go to the swimming pool because I look badly. And we found out that the appearance-related distress was pretty high. In green, you have women with lipedema in different ages, group ages. And in gray, you have general population women. And in blue, there is a clinical population. These are women with facial differences in appearance, mostly facial or skin. So as you can see, appearance-related distress in this group is pretty high. And here are some examples of questions. How distressed you are by being unable to wear your favorite clothes? Or how distressed do you get when you go to the beach? Many people get extremely distressed. So you may imagine how it impacts their quality of life, their psychological functioning, and then mobility and pain. I'm very self-conscious of my feature being lipedema, or I'm afraid that often people misjudge me because of my feature. And why the appearance-related distress is so high in this group? Well, because lipedema is mistaken as obesity, and as I said before, weight stigma is prevalent. Recently in June, I was at a conference in Bath about appearance, and Rebecca Poole, who is the author of the studies around weight stigma, she showed this slide. As you can see here, we have explicit weight stigma. Explicit means that I'm openly saying that I stigmatize people who are fat. I openly say that they are fat and lazy, that's okay. You can see Sweden, well, not so bad. There are countries when it is worse. But at the second picture, we have implicit with stigma. So I'm not saying openly that I stigmatize people, but when you measure it unconsciously, I stigmatize them. You can see Sweden, it's much higher. So it is very prevalent, and I guess it needs a lot of changes at the level of general population or politics. And there is a number of research showing that weight stigma is worse for our health than actual obesity, fat, or any other disease. It affects our health, it leads to psychological disorders, it lowers physical activity, might lead to binge eating, increased calorie intake, physiological stress, which is very unhealthy for lipedema patients, and weight gain. So it seems that there is a number of negative effects of stigmatization. But the question is what to do in such a world where weight stigma is so prevalent. And I'm very pragmatic, so I always tend to ask to focus on what you actually can change and not on what you cannot change. So I would say that first of all, we need to notice when do we experience appearance-related distress, in what situations. Or if you are working with a patient, you might ask them, is appearance-related distress stopping you from something? Let's talk about it. Are you stressed about the way you look like? May I do something to make you feel more comfortable with me or with the things that you are supposed to do? And then, what would you do differently if you are proud of the way you look like? Let's do this little exercise, like let's imagine that there is no pain, there is no problem with mobility with lipedema, and that one day lipedema becomes the ideal body look, and everyone wants to look like you. And people come and say, what have you done to look like that? This is amazing, I want to do the same. And you become proud of your body. How your day would look differently? What would you do differently? How would you take care of your body differently? And do it now. Mm-hmm. I mean, we have this only moment. Our body, no one have chosen to have lipedema. No one said, oh yes, I want this. I want to feel this pain. I want to look like that. We haven't chosen it. But this is our body, and it functions as good as it can. Even now, when you are sitting here, your body is alive, your lungs are breathing, your stomach is digesting, your blood is circulating. So there are some functions of your body that are working well. And there are some functions of your body that are not working well. And that is this body diversity that we encounter. So I would suggest to think about it, or give you this food for thought. You can think about it later on, that your body actually is doing a pretty good job to keep you alive, even if it's not looking as someone said that it should look like. So I would suggest to celebrate body diversity, and I use this picture because this is a great metaphor, that each of us gets a brush to paint a picture of our lives, and some people get very thin brush, and some people get very thick brush, but with each brush we can paint a beautiful picture of our life. I would even go further than that. I would suggest to advocate for body diversity. So change the way you speak about yourself, change the way you speak about your bodies. If someone actually comments on the way that someone looks like, react to that. We need a change in the society. We need a change of body ideals. We need body diversity. And after this moving moment, I will move to psychological functioning. Back to science again. we measured that because it seems like many women, when they go on a diet, they tend to be very restrictive about their eating. And we know from research that going on a diet increases the likelihood of having eating disorder. So we wanted to check if women with lipedema have eating disorders. In the first study, in green we have results for each scale on the eating disorder questionnaire in women with lipedema. It is pretty high. In second study, we haven't measured the questionnaire, we just asked, do you suffer with eating disorder? And 30% of women said yes. This is much more than in general population, where it's like 5 to 6% of women. Why is that so? As I said before, according to some theories, if we are trying to diet, we will either stop trying to diet and get the weight that we lost, or we can develop eating disorders. So eating disorders might be common in this group. And the problem is that because of weight stigma, because of making mistake of thinking that lipedema is obesity, we are very often given an advice, go on a diet, eat less. And we eat less and less and there is no result. So that might lead to a lot of problems, especially in the area of eating. So what to do if you have lipedema and you want to eat well? Well, I would suggest to find a way of eating that will be yours, that you feel good about, that support the way you want to live, that suits your health and has good long-term consequences. So no restrictive dieting, but just finding your own way. It might take some time. If you are a physician or a physiotherapist, you might help your patient to find this way of eating. And that must be a way of eating that allows you to enjoy your life to some extent. And we tend to become more mindful about what we choose to eat. So this is a process of choosing again and again what to eat. So first of all, we need to be aware of those moments of choice. So be aware of when I have an urge to eat something unhealthy that would be unhealthy for me, what I want to choose to eat. And to choose wisely. What I mean by choosing wisely. So for example, I might say to myself, okay, I'm seeing this cake, I really want to eat it and I will feel well for 20 seconds, but then I will feel the pain the next day. So maybe I will choose not feeling the pain the next day, and I will not choose the cake but vegetables. But on the other hand, sometimes we might allow ourselves to eat something just to feel the pleasure. So choosing wisely is the next step, and then surf the wave of discomfort. Sometimes we need to actually feel the discomfort of saying no to a cake, let's say, or something else. And I say surf the wave because as discomfort, as the wave, it passes. When we wait enough, it will pass. But the most important thing is to enjoy the food. Like children do. Have you ever saw a child eating a little piece of chocolate all over the place and touching it and playing with it? We forgot about it because we have the whole history of trying to restrict, trying to change the way we look like. But actually food is nothing bad. We need to learn again to enjoy it. And we also investigated anxiety and depression in our study. So anxiety was pretty common. It shows moderate to severe anxiety in our second study. And the most important here that I wanted to focus focus on is depression because of the consequences of depression for the whole functioning. We found that it's really important for quality of life. Moderate to severe, more than 50% of participants. Why is it so common in this group? So we think that it's very common because this disease is difficult to control, unpredictable in some ways. It takes time to find a good treatment. There is a lot of obstacles, I heard about it, to find a treatment, proper treatment. The other thing is, if we have a history of restrictive dieting, it might lead to malnutrition, and malnutrition might lead to depression because of lack of nutrients. Also, pain itself is connected with depression. Lack of physical activity, I said about it earlier. Loneliness, when we are not mobile, we cannot meet with friends, or we feel ashamed and we don't have friends anymore. Experiences of fat shaming, weight stigmatization, and there are some theories talking about neuroinflammation in depression that connect those two. And why depression is so important for quality of life? Because people with depression have really hard time to engage in physical activity. So the depression might actually lead to becoming less mobile. And then when we are less mobile, it's most probable that we will have higher depression. So it's a kind of vicious circle, a loop. Depression might lead to weight gain because it's much harder to make wise choices, to eat more healthier. We feel like we don't have energy, we have all these negative thoughts, we feel bad. So the possibility of gaining weight is higher, and then with weight gain, we might increase the severity of depression. People with depression experience more pain than people without depression. And then people with pain experience more depression. There is a big discussion in scientific world, what causes what, or maybe they co-occur together. And then depression is related to staying indoors, and that is leading to losing social connections. When we say, I will not meet you, I will stay tonight in bed, I'm too tired, I'm feeling sad.